Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we are now going to move on to ventricular arrhythmias, arrhythmias arising because of problems in the ventricles. Okay, and the first thing that we're going to talk about is ventricular ectopic beats, which is exactly the same principle as what we've seen with atrial ectopic beats, except that now it's actually occurring in ventricular tissue rather than atrial tissue. Okay, so ventricular ectopic beats are often denoted VEB for short, or VEBs, so ventricular ectopic beats. So the principle is that we're going to have an ectopic focus or potentially ectopic foci within the ventricular wall tissue, and these ectopic foci will be these areas of cardiomyocytes that are suddenly capable of generating spontaneous electrical signals. They fancy the job of the sinoatrial node and they gain the ability to actually generate spontaneous electrical signals. Okay, now we're not going to go into the mechanisms by which these cells have actually gained the ability to do this. The mechanisms aren't very well understood. As you can imagine, loads of different mechanisms have been proposed, so it's a nightmare at the moment. No one's in agreement as to exactly usually what causes this. Okay, so we're not going to go into the theories of how these cells have actually gained the ability to do this, but for our purposes we will go on the cellular level. They are doing this. Okay, so firstly what I want to talk about is what will this actually look like on the ECG, and then what I want to talk about is if this is very severe, if we've got an ectopic focus that is firing out electrical signals at a ridiculous rate, how can we actually treat that? Because there is an incredible way of treating it. Lidocaine is incredibly good at preventing ectopic foci from sending out electrical signals, provided that they are sending out these electrical signals at a ridiculously high rate. And what I want to really explain to you, the main thing that I'm going to explain to you in this video, is how is it that lidocaine blocks electrical signals that are occurring too frequently but doesn't block electrical signals that are occurring not too frequently. Okay, and that mechanism is what we're really going to focus on in this video. But firstly, let's talk about what the ECG is going to look like. So we're going to have some ectopic focus in the ventricular wall, so somewhere in the ventricles. Now, of course, the ECG is going to depend on where the ectopic focus actually is. Now, of course, the ECG will contain normal heartbeats, normal electrical signals that are propagated through the heart in the normal way and which originated from the sinoatrial node. So I've just put one of these in. So here is the normal P wave, the normal interval between the P wave and the QRS complex. Here is the normal QRS complex, and then the normal T wave here. But then in between the normal cardiac beats, you might then have an ectopic beat, and if it's going to be a ventricular ectopic beat, it's going to be arising somewhere from within the ventricles. Now, of course, this will depend on where it's actually arising from in the ventricles. If it's arising from right at the bottom of the ventricles, then of course it's going to be propagating upwards, and therefore you're going to get a huge deflection downwards on the lead 2 ECG for ventricular depolarization. So let's go very extreme. Let's say our ectopic focus is down here. Then of course the wave of depolarization will spread in this retrograde fashion, and therefore on our lead 2 ECG we'll get a large deflection downwards for that portion of retrograde conduction up the ventricles. Of course, it will also spread to the ventricular conduction system, and through the AV nodes will then get back up to the atria, and you'll also get retrograde conduction up the atria as well, and that will also be part of this. Maybe we'll also get something like this, which is the retrograde conduction up the atria. So have a little bit of a think about this. You'll see that depending on where the ectopic focus is actually positioned, you can get very, very different ECG patterns for a ventricular ectopic beat. If it was positioned right up at the top here, somewhere up at the top, then of course ventricular depolarization would spread in an anterograde fashion, so you'd get an upward deflection. But then when it's spreading to the atria via the ventricular conduction system, it would be going up in a retrograde fashion, so you'd still get a downward deflection for the atria. So it will vary depending on where the position of the ectopic focus actually is. Okay, but the point is very, very odd QRS complexes amongst the normal ECG patterns is the way that a ventricular ectopic beat will be seen on an ECG, on a lead 2 ECG here. Okay, right, so this isn't usually a problem as long as the ectopic focus isn't actually generating electrical signals at a too high frequency. So if it's just throwing a few off a minute, then it's not going to cause a problem. As long as the ventricles are still getting a chance to relax properly down in between concurrent beats, then we're still going to get proper ventricular filling, and it's not going to damage cardiac output that much. Okay, the problem of course arises when these ectopic foci start chucking electrical signals out at some ridiculous rate, and then of course you can end up with massive ventricular tachycardia, and then the ventricles won't be relaxing properly down in between concurrent beats, and you won't therefore be getting a proper stroke volume, damaging cardiac output. That's the dangerous bit. Now, how can we treat this? Well, what I want to talk about is the drug lidocaine, which can be used incredibly to stop the electrical signals that are coming too rapidly from an ectopic focus from actually spreading to the rest of the myocardium. Okay, so firstly let me give you the big picture of what lidocaine is going to be capable of doing. Let me make you truly amazed by what lidocaine is capable of doing, and then let me show you the rather complicated but incredible mechanism by which it actually achieves what it does. Okay, right, so let's say we have our ectopic focus here. So let's say we're just looking at a piece of the myocardium, the ventricular wall here, and let's say this portion in orange here is my ectopic focus. So let's say this is the ectopic focus. So this is either a single myocardial cell or potentially a cluster of myocardial cells which are now capable of generating electrical activity spontaneously, and we're going to say they're generating it at a ridiculous rate. So they are chucking out electrical signals at some stupid rate. Okay? What we want to do is we want to stop the myocardial cells that are around them from actually conducting the electrical signals coming from these silly ectopic foci cells here. Okay, so we want to somehow stop the myocardial cells that are surrounding this ectopic focus. So let's say these are some ventricular myocardial cells surrounding this ectopic focus. We want to stop them from conducting the electrical signals that are coming from the ectopic focus. Now, how is this going to work? Well, the way lidocaine is going to work is it's going to stop these cells from conducting electrical signals at too rapid a rate. So if these cells are being stimulated to conduct action potentials at a too high rate, then lidocaine is going to stop them from conducting them completely. Whereas it will not stop myocardial cells all over the heart from conducting action potentials at a reasonable rate. So if a myocardial cell is being stimulated to conduct an action potential at 75 beats per minute, a perfectly reasonable healthy rate, lidocaine will not influence that at all. It will allow the cardiomyocyte to still conduct that electrical signal. Okay, all of them, all 75 of them. Whereas if it's being stimulated to conduct action potentials at a ridiculously high rate, lidocaine will stop it from conducting every last one of them. Okay, not just cutting it down to a sensible level, but it will stop every single one of them. So that's the incredible thing that lidocaine can do. It will go into the cardiomyocytes all over the heart, and it will allow them to conduct action potentials up to a certain level, and then if they're being stimulated to conduct action potentials at a level higher than some certain amount, it will cut it off completely. It will say, no, we're not conducting anything then. It will shut their conduction of action potentials completely down. That is the incredible thing that lidocaine is capable of doing. So if we have an ectopic focus that is throwing out electrical signals at a ridiculous rate, then these surrounding cardiomyocytes, which have now been exposed to lidocaine, they will just shut down their ability to generate action potentials, and therefore they won't conduct the electrical activity from the ectopic focus to the surrounding myocardial cells around them, and therefore the ectopic focus has effectively been silenced. Okay, so that's the incredible thing that this drug, and I'll write down its name because I haven't done so yet, this drug lidocaine, also called lignocaine. Lignocaine's its old name, so you might hear old clinicians calling it lignocaine, but it's been renamed, God only knows why, to lidocaine. Both names are acceptable. Okay, so this drug lidocaine is capable of actually doing that, and we want to now understand how. How is it capable of stopping myocardial cells from conducting action potentials at all if those myocardial cells are being stimulated to do so at a far too high rate? Okay, so to understand this, we are going to need to understand voltage-gated sodium channels in more detail, because lidocaine blocks voltage-gated sodium channels like flecainide, but its kinetics, its way of binding to them, is different to flecainide. I will come back to flecainide, and I will contrast it to lidocaine and explain how what they are doing is different, and why flecainide is therefore used to do something different to lidocaine. Okay, so firstly, let's study voltage-gated sodium channels in more detail. So let's say this is a cell membrane here, and I'm going to draw voltage-gated sodium channels in my cell membrane. So, when the electrical potential difference across the cell membrane is below negative 40 millivolts, let's say the electrical potential difference is less than negative 40 millivolts, so it's below the threshold potential for the activation of voltage-gated sodium channels, then the stable state for a voltage-gated sodium channel to exist in is the resting state, okay, which is a non-conductive state. It's a closed state. Sodium ions are not able to come through it in this state. So this is what's known as the resting state. So when the electrical potential difference across the cell membrane is below threshold potential, all of the voltage-gated sodium channels are in this resting state. They are not conducting sodium ions. Now, as I discussed in the previous video, when you go beyond threshold potential, the stable state for a voltage-gated sodium channel to be in is not the open state, it is the inactivated state. However, to get to the inactivated state, it has to go through a transient state, which is the open state. So when you go to greater than negative 40 millivolts, when you depolarize beyond threshold potential, voltage-gated sodium channels will temporarily move into what's known as the open state, where they do allow sodium ions to move through them. However, this is just a transition state. It's basically they're moving into a different state, and for a while they sit in this intermediate state, which is the open state, but this is not a stable state for them to be sitting in. Okay, so I'll colour this open state here in green, and this is the state where they can actually allow sodium ions to move through them. Okay, so this is a transient state, so I'll just put transiently they go into this state, and then if you keep the electrical potential difference above negative 40 millivolts, they all just end up going into the state that they're actually stable in above negative 40 millivolts, which is the inactive state. Okay, and this is where a little portion from the intracellular side has gone in and plugged in the hole effectively. Okay, this is their stable state. So this is the actual nature of the inactivated state. They usually have some sort of part of the channel that is capable of going in. It's usually an intracellular part of the channel that's capable of folding back into the pore, and it nicely sort of stably sits in there and blocks sodium ions from being able to move through. So this now is what's known as the inactivated state, and this is the stable state for a voltage-gated sodium channel to exist in when the electrical potential difference is greater than negative 40 millivolts. So really, this is what voltage-gated sodium channels move into when you move the electrical potential difference above negative 40 millivolts. Below negative 40 millivolts, this is their stable state. Above negative 40 millivolts, this is their stable state. But to go from this state to this state, you have to go through the intermediate state transiently, which is the open state. Okay, so if you go above negative 40 millivolts transiently, you'll go into the open state, and then you'll move all into the inactivated state. If you keep the electrical potential difference depolarized beyond threshold potential, they all just sit in the inactivated state. Okay, so then if you want to open them again, what you need to do is you need to repolarize the electrical potential difference across the cell membrane down to negative 40 millivolts. When you do that, what happens is Firstly, they go back from the inactivated state to the open state, and then extremely quickly they go back from the open state to the resting state. Okay, so understand this. When you depolarize the electrical potential difference to beyond negative 40 millivolts, they moved to the inactivated state through the open state, and they stayed in the open state for a short but a reasonable time that actually allowed sodium ions to come through. When they go in the opposite direction, when you repolarize the electrical potential difference across the cell membrane to below negative 40 millivolts, again they have to go through the transition state of the open state. However, they stay in it for a ridiculously short time, even shorter time than they did when they were going forwards. Okay, so really you don't actually let any sodium ions move through in that bit. Okay, you jump straight through. Okay, whereas on the forward direction you sit here for a little bit longer before you go into the inactivated state. Okay, so these arrows all have names. This process where you go from the resting state to the open state is called activation. This process where you go from the open state to the inactivated state is called inactivation. I'm sure you're aware of those ones, so I won't bother labeling those ones up, but I will label these two. When you go from the inactivated state back to the open state, when you've repolarized, so this will occur when you've repolarized, that process is known as de-inactivation. Okay? And then when you go from the open state back to the resting state, that's known as deactivation. So when you repolarize the electrical potential difference across the cell membrane, you firstly go through de-inactivation. You're transiently, ridiculously transiently, so transiently that no sodium ions are actually going to go through it. You're transiently in the open state, and then you undergo deactivation back to the resting state. Okay, so there's a brief summary of how voltage-gated sodium channels actually go between the different states. Now, let's actually use this to understand what lidocaine does. So firstly, we're just going to talk about what lidocaine does in the context of a single voltage-gated sodium channel, and then we'll go back to our actual problem and put it all together and explain how lidocaine is actually going to achieve this effect of stopping cardiomyocytes from conducting action potentials whatsoever if they're being stimulated to do so at a far too high rate. Lidocaine is capable of binding to voltage-gated sodium channels and blocking the pore, okay? But it does so in what's called a use-dependent manner. So lidocaine is referred to as use-dependent. People use this description of lidocaine, okay? And what this means is that lidocaine only binds to voltage-gated sodium channels when they are actually being used, okay? It does not just bind to a voltage-gated sodium channel no matter what state it's in. Okay, so if I had a drug which just binds to a voltage-gated sodium channel and doesn't care which of these three states it's in, then it would be non-use dependent. Okay, it would just bind all the time to voltage-gated sodium channels and it wouldn't care what state they were in. A use-dependent drug is going to be one that binds with different affinities to the different states, and lidocaine, it likes to bind to the open state. It doesn't like to bind to voltage-gated sodium channels that are in the resting state. So if you've got your cell, your cardiomyocyte, it's obviously got loads of voltage-gated sodium channels in its cell membrane, then when you're in the resting electrical potential difference across the cell membrane, below negative 40 millivolts, not much lidocaine is going to be bound to those voltage-gated sodium channels. And in fact, I think I'll start to draw my picture here. So let's say here is my cardiomyocyte here. So when it's in the perfectly resting state, so I've got it just on a plate, it's not doing anything, it's not conducting any electrical signals, it's got an electrical potential difference across its cell membrane of negative 80 millivolts, then no lidocaine, even though there's lots of lidocaine in the surrounding fluid, will actually be bound to the resting state voltage-gated sodium channels, because it's not got a very good affinity for them. When they actually start opening, so when you depolarize the electrical potential difference across the cell membrane to beyond negative 40 millivolts and the voltage-gated sodium channels open, that's when lidocaine binds, and it binds and blocks the pore. Okay, so it goes in and blocks the voltage-gated sodium channel. Okay? Then, when it moves into the inactivated state, the lidocaine remains bound in the inactivated state. So in fact I'll draw this. So let's say here is the lidocaine, and it remains bound to the voltage-gated sodium channel even in the inactivated state here. So here's the lidocaine drug, okay, and it remains bound in the inactivated state here. Okay, Now, here's the incredible thing. Lidocaine stabilizes the inactivated state. This is what it's believed to do. It's believed to stabilize the inactivated state. So whilst we keep the electrical potential difference beyond negative 40 millivolts, of course, the channel will remain in the inactivated state and the lidocaine will just remain bound there. But let's say now we go back to below negative 40 millivolts, so we repolarize the electrical potential difference across the cell membrane. The desire now is that the inactivated voltage-gated sodium channel wants to undergo de-inactivation and then deactivation because the electrical potential difference has returned to being below threshold potential. However, the lidocaine stops it from doing that. At least for a while, it stabilizes the inactivated state. So this is a line that people love with the description of how lidocaine works. Stabilizes the inactivated state. Okay, so it keeps the voltage-gated sodium channel in the inactivated state for much longer following repolarization of the electrical potential difference across the cell membrane than it would without the drug bound to it. Okay, so now we've repolarized, but lots of the voltage-gated sodium channels are going to remain in the inactivated state even though we've gone back to being below threshold potential because they've got the lidocaine bound to them. Now eventually what will happen is the lidocaine will fall off and then the voltage-gated sodium channel will go back to the resting state, and we know that when it's in the resting state the lidocaine doesn't bind to it. Okay, but it takes longer than usual. Okay, so it takes longer to get the voltage-gated sodium channels back into the resting state. So what are we going to be resulting in here? We are going to be resulting in the refractory period of the cell membrane being increased. Okay, to understand why, because it's going to take longer for the voltage-gated sodium channels to recover to being in the resting state following an action potential. That's the key to what lidocaine does. Remember, voltage-gated sodium channels go through this cycle every action potential, and in order for them to be ready to conduct another action potential again, we need to have got the inactivated channels back to being in the resting state. This is going to make sure that it takes longer for that to happen. Okay, so let's now put this all together and understand why, if we've got one cardiomyocyte here trying to stimulate this next one, and this one's been exposed to lidocaine, why, if it's being stimulated at a reasonable frequency, the action potential will occur, whereas if it's being stimulated at far too high a frequency, no action potential will propagate along the cardiomyocyte. Okay, so let's firstly just draw a gap junction here. So this is our gap junction. Right, so every, with a certain frequency, this cardiomyocyte will be stimulating this one, i.e. giving it positive charge. Now, let's say this one does it for the first time, so we're starting the clock here, we're starting the process. I know it's a cycle, but we have to start somewhere. So let's say we have just exposed everything to lidocaine, so lidocaine's everywhere now, okay, and now we're looking at the first time that cardiomyocyte number 1 here attempts to stimulate cardiomyocyte number 2. Okay, what's going to occur the first time? Well, at the moment, all the voltage-gated sodium channels in cardiomyocyte number 2 are in the resting state. Lidocaine is not bound to them, so everything's fine. So what will happen now? Positive charge will come in, that will activate the voltage-gated sodium channels, okay? They will go into the open state temporarily, and they will allow in sodium ions. Now, when they're in the open state, some of them will now start getting lidocaine molecules bound to them, which will block them. However, this is the absolutely key thing to understand. The drug does take a certain amount of time to come on. It's not a case that you open your voltage-gated sodium channels and the instant that that occurs, lidocaine binds and blocks. It takes a certain amount of time. You know, the drug molecule has to just happen to bash into the voltage-gated sodium channel at the right place with the right amount of energy for it to actually bind. Okay, so it does take time for voltage-gated sodium channels to actually get blocked by the lidocaine, and by the time that you've blocked quite a few of the voltage-gated sodium channels with the lidocaine molecule, you've already got a lot of sodium ions coming through. Okay, so let me draw this here. So you already have lots of sodium ions coming through. So you have already got a considerable upstroke of your action potential. Yes, being exposed to the lidocaine will have disrupted the upstroke of the action potential, the upstroke will now be smaller, but it's not so small that you are not going to get saltatory conduction. Okay, so the key thing to understand here is that even in the presence of the lidocaine, you're still going to get enough sodium coming in before the lidocaine has actually blocked the voltage-gated sodium channels considerably enough to stop sodium coming in. Okay, so you're still going to get a good upstroke of your action potential, and of course that positive charge coming in is then what causes the saltatory conduction. So now what will happen is that will be good enough to spread to the neighbouring portion of the membrane here, and then the same thing will happen at this neighbouring portion of the membrane. Again, the voltage-gated sodium channels will open, they'll allow in a lot of sodium before the lidocaine actually has blocked most of them. Okay, so you'll still get a good upstroke and the action potential will still conduct. Yes, it will conduct slightly slower now because the upstroke has been damaged, but the point is it still conducts. Okay? Right, so the action potential will still propagate. Yes, slightly slower because the upstroke's been damaged by the lidocaine. But let's now think about what's happening in this portion of the membrane here. So this portion of the membrane, let's say, has gone through its action potential now, and it's now going into the repolarization portion. Okay, its voltage-gated sodium channels will now be in the inactivated state with the lidocaine bound. Okay, and if we have now repolarized the electrical potential difference, we know that the lidocaine is going to stabilize the inactivated state, and it's going to take a certain amount of time to get them back into the resting state. Now, if you wait long enough, okay, if cardiomyocyte 1 is not trying to stimulate cardiomyocyte number 2 too quickly, then if you wait long enough, the lidocaine will fall off all of your voltage-gated sodium channels and they will all return back to the resting state. So if you wait long enough, everything's fine. Okay, your voltage-gated sodium channels will go back to being in the resting state, and then cardiomyocyte number 1 can stimulate cardiomyocyte number 2 again, and an exact repeat of what I've just described to you will occur. You will get an action potential propagating along cardiomyocyte number 2, albeit at a slightly slower rate because the upstrokes are slightly compromised because of the lidocaine blocking the voltage-gated sodium channels. But the point is the action potential will conduct. Now let's think about what would happen if cardiomyocyte number 1 tried to stimulate cardiomyocyte number 2 far too quickly, i.e. this might be an ectopic focus cardiomyocyte here, trying to stimulate this one at a ridiculously high rate. Okay, then what will happen is you'll be getting positive charge coming through this gap junction here before the voltage-gated sodium channels have actually recovered, i.e. they're still in this inactivated state with the lidocaine bound, even though the electrical potential difference is back at a repolarized level below threshold. Because of the presence of the lidocaine, they haven't actually gone into the resting state. So lots of them are now still in the inactivated state with the lidocaine bound. Okay? A few of them will have gone back into the resting state. Some of them, the lidocaine will have dropped off by now and they'll be in the resting state. So what you'll do is you'll get those to open. You might you'll depolarize the electrical potential difference up to be above threshold with the positive charge coming from the gap junction here. That will activate the few that have returned to the resting state to open again. Okay, now that you're back above threshold, the inactivated state is the stable state, so these ones that were still in the inactivated state with the lidocaine bound, they're not going to now be wanting to change back. They're quite stable and happy, so they just remain closed and are not conducting any sodium. The few that were in the resting state and had recovered, they will go into the open state and they'll start to get the lidocaine blocking them. Before the lidocaine's actually blocked them, they will let in a bit of sodium and you'll get a tiny little upstroke of your action potential. Okay, so I hope you understand what's happened here. A few have recovered by the time you've provided the next stimulation to take us to an electrical potential difference across the cell membrane beyond the threshold potential, but very few have actually recovered so far. Okay, so you're only going to get a tiny number opening. Okay, those will now get lidocaine binding to them and blocking them, so you'll get a tiny little amount of sodium coming in here, and that tiny little amount of sodium might not actually be good enough to cause saltatory conduction at all, i.e. it might not spread to the next bit, and that's then how the action potential can be completely blocked. Okay, so if the upstroke of the action potential is small enough then you won't get any saltatory conduction, and therefore the action potential will not conduct. And that's how lidocaine is going to block action potentials from conducting in these cardiomyocytes that are being stimulated at far too high a rate. Now note also, every time this cardiomyocyte number 1 does stimulate cardiomyocyte number 2, it is just reaffirming the block, because those voltage-gated sodium channels that were in the resting state when it performed stimulation number 2, those that had recovered, they've now gone into the open state, let in a measly little bit of sodium, but in the process they got blocked by lidocaine, and they will then go into the inactivated state with lidocaine blocking them. So they're now back in that state. So now what's going to happen is you've returned to having most of your voltage-gated sodium channels in this inactivated state with lidocaine bound to them. You'll then undergo the repolarization phase down to below negative 40 millivolts again, and then what will happen? A few of them will get a chance to recover again, and then you'll get another stimulation from cardiomyocyte number 1 because it's stimulating far too frequently, and then the same thing happens again. You've only got very few in the resting state, all the others are still in the inactivated state, and those that are in the resting state, when they go into the open state, they're not going to allow in enough sodium to actually get an action potential that will conduct by saltatory conduction, so it doesn't cause an action potential, and all you end up doing each time is re-blocking those voltage-gated sodium channels that had the chance to recover. Okay, so overall this is the reason that lidocaine is capable of blocking action potentials from conducting at all in cardiomyocytes that are being stimulated too frequently. Whereas if the cardiomyocyte is being stimulated at a reasonable frequency, then all of the voltage-gated sodium channels, or at least enough of the voltage-gated sodium channels, have the time to recover in between the stimulations, and therefore you will get a large enough upstroke for the action potential to actually conduct by saltatory conduction. Okay, so that is how lidocaine is actually going to work to block cardiomyocytes that are being stimulated to undergo action potentials too frequently from conducting action potentials whatsoever. Okay, so I hope you've understood that. What I now want to end with is a discussion of why flecainide is different. Okay, because flecainide also blocks voltage-gated sodium channels, but it works in a different way to lidocaine. Well, actually, it works in a very similar way to lidocaine. It's use dependent as well, so why does it not do the exact same thing as lidocaine? We talked about how flecainide could be used to slow conduction of action potentials down in the His-Purkinje system, cardiomyocytes, and we used that in the atrioventricular node reentrant tachycardia to try and prevent the circus rhythms that were occurring in the AV node from all getting down to the ventricles. Okay, so how is flecainide different from lidocaine? Well, flecainide does this exact same thing as lidocaine. It binds to the voltage-gated sodium channels when they're in the open state, blocks them, and then when they go into the inactivated state, it likes to be bound to the inactivated state as well, and it stabilizes the inactivated state. However, flecainide is what is described as slow on, slow off. Okay, whereas lidocaine is described as fast on, fast off. Okay, and we'll see that lidocaine is actually categorized in the Vaughan-Williams classification of antiarrhythmic drugs as a class 1B drug, and flecainide is classed as a class 1C drug. So class 1 drugs are drugs which work by blocking voltage-gated sodium channels, and I think we've now seen all of the 4 classes of antiarrhythmic drugs. So class 1 is the voltage-gated sodium channel blockers, and we've seen now lidocaine and flecainide. It's split into 1A, 1B and 1C. We've seen an example of a 1B one, which are these fast on, fast off voltage-gated sodium channel blockers, such as lidocaine. 1C drugs are slow on, slow off voltage-gated sodium channel blockers, and an example is flecainide. 1A drugs, I'll talk about those right at the end. They're not used really anymore. They're somewhere in the middle between lidocaine and flecainide. They're intermediate speed on and intermediate speed off. Okay, examples of things like quinidine, but they're very rarely used as antiarrhythmics anymore. Class 2, remember, are the beta blockers. Class 3 are things like amiodarone, which lengthen the cardiac action potential by blocking voltage-gated potassium channels and slowing down the repolarization phase, therefore. And Class 4 drugs are calcium channel blockers, such as verapamil and diltiazem. Okay, but we will go over all of that right at the end. I'm just sort of talking about it as I go along so that we'll have an easier job at the end. Okay, right, so flecainide and lidocaine. So what does this mean? Slow on, slow off, and fast on, fast off. Lidocaine being a fast on, fast off means that when voltage-gated sodium channels actually go into the open state, lidocaine will bind very quickly. Okay, so when you have a cell exposed to lidocaine, by the end of the upstroke of the action potential, a lot of the voltage-gated sodium channels will have ended up getting lidocaine bound to them because it's very good at binding to them quickly. Okay? Being fast off then means that when they have gone into this inactivated state, and now the electrical potential difference across the cell membrane is back below negative 40 millivolts, they will come off reasonably quickly as well. Okay? Slow on, slow off means that flecainide will bind very slowly to voltage-gated sodium channels, and then when it's time to come off, when we're in the inactivated state and we're now repolarized below negative 40 millivolts, it takes them absolutely ages to actually come off. Okay? Now, this means that lidocaine can actually come on and off of voltage-gated sodium channels in between individual action potentials in the way that I've just described to you, whereas flecainide doesn't do this. You can't do this with flecainide. Instead, you give flecainide in a low enough dose such that it will block a certain fraction of the voltage-gated sodium channels, and it just does that at a steady state. Okay, so because of the different kinetics, this one ends up just blocking a bunch of voltage-gated sodium channels at a sort of chronic level, or tonic level is probably the better way of saying it. Okay, so let me describe better what I'm trying to say here. So, if I have a cardiomyocyte here, and I expose it to flecainide, the actual functional effect of this is that you're just going to take out a whole bunch of the voltage-gated sodium channels. So let me draw some voltage-gated sodium channels here. In fact, I won't draw them necessarily in the open state here, but I'll have them in different states. Or well, actually they do need to be in the inactivated state for the drug really to be bound, because it doesn't have that much affinity for the resting state, so I should probably have them drawn in the inactivated state here. So that's how I'll do it actually. I'll draw a few of them in the inactivated state here. Okay, and then some of them should be in the resting state, yes. This is the way of doing it. Okay, ignore me at the moment, I'm just talking to myself. Okay, right, so here's my picture then. So we've got our cardiomyocyte here, and let's say it has been exposed to flecainide for a very long time, and we've also had it undergoing stimulation. Okay, so it has been opening these voltage-gated sodium channels from time to time, so it's been going through a cardiac cycle, let's say, for a reasonable amount of time, and every single time it undergoes a cardiac cycle, some of the voltage-gated sodium channels, whilst they're in the open state, will end up with a flecainide molecule bound to them, and then when they're in the inactivated state, they'll still have that flecainide molecule bound to them, and they'll remain in the inactivated state for absolutely ages once they've got the flecainide molecule bound to them. Okay, unlike lidocaine, where they don't remain in the inactivated state for as long once they've got the molecule bound to them. So these ones here that are shown in the inactivated state, with a flecainide molecule bound here, these are the ones that are effectively useless now. Okay, so every time you undergo a cardiac cycle, a few more voltage-gated sodium channels will end up getting the flecainide molecule bound to them. Now, it'll build up is what I'm trying to say here. If you take your cardiomyocyte, and initially all of the voltage-gated sodium channels are in the resting, perfectly happy state, and then you expose them to flecainide for the first time, and then you stimulate that cardiomyocyte to undergo an action potential so that all of the voltage-gated sodium channels are going to go through the cycle of being open and then inactivated and then going back to resting. Not all of the total number of voltage-gated sodium channels that flecainide could block will have been blocked. okay, it won't have reached the dynamic equilibrium yet. So the starting bit will be that a few of them get blocked because the fleconide's so poor at actually binding to them quickly. Its kinetics are so slow, it will block only a tiny number of them. But then once they've been blocked, they will stay in that inactivated state with the drug bound to them, even though the electrical potential difference has gone down to being below negative 40 millivolts. They'll stay in that state for a long time, as I've shown here. Now, the next time that we trigger this cardiomyocyte to undergo an action potential, those will still be in that same state. And well, a few of them will recover, a few of them will actually drop their drug molecule off and go back to the resting state, but most of them will still be in that state shown here in blue. Okay, and then the next time the action potential occurs, again, all the ones that were in the resting state will go into the open state, and a few of them will get bound to fleconide, and then they'll go into this state as well. So what I'm trying to say is that when you expose the cardiomyocyte for the first time to fleconide, and then it goes through cardiac cycle after cardiac cycle after cardiac cycle, action potential after action potential after action potential, the block will gradually build up to a steady state where the number of these channels that recover in between each cardiac cycle, i.e. return to being in the resting state, will be equal to the number that you re-block. So effectively, the way fleconide works, because it's so slow on and slow off, is that you establish a steady state of just a certain percentage of the voltage-gated sodium channels being in this blocked state. Okay, and as I said earlier, we'll take as an example, maybe you've blocked 30% of them. I know in this picture it's 50%, that's probably a bit extreme. But let's say we give the correct dose of the drug such that around 30% of the voltage-gated sodium channels at any one time are going to be utterly useless. That's the overall effect of fleconide. Because its kinetics are so slow on and slow off, it doesn't really matter that it's use dependent. The overall effect of it is that it just takes out effectively a certain fraction of the voltage-gated sodium channels and makes them useless. And therefore you don't want to give it in too high a dose, because you could end up blocking all of the voltage-gated sodium channels permanently. You give it in a dose just to take out a certain fraction of them, so that that can then slow down the conduction of the action potential in the His-Purkinje system. Okay, so that's the use of fleconide. Now let's go back to lidocaine and try and contrast it. In lidocaine, you will give it in a bigger dose so that it's actually capable of blocking a much higher fraction of the voltage-gated sodium channels at any one time. But the difference is that lidocaine, because it's so fast on and fast off, it will actually come on, all of the molecules will come on and block the voltage-gated sodium channels, and then they'll all come off again in between each cardiac cycle, whereas fleconide, because it's slow on and slow off, it doesn't do that. Okay, it builds up after each action potential, okay, to a steady state where finally the number that you put on with each action potential is equal to the number that you drop off in between each action potential. Okay, whereas lidocaine, because its kinetics are much faster, it's going all on and then coming all off in between each action potential. Okay, and that's how it can actually block action potentials in these cardiomyocytes that are receiving stimulation too frequently. So I'll just go over the mechanism of lidocaine again, because I just want this really to be firm in your head. So, remember, if we've got this cardiomyocyte number 1 that is stimulating cardiomyocyte number 2 at a reasonable rate, then what's going to happen is when this positive charge arrives here, the voltage-gated, well, that will depolarize the electrical potential difference up to beyond threshold potential. All of the voltage-gated sodium channels will now be in the resting state, okay, ready to actually go into the open state. They'll go into the open state transiently. A lot of them, by the end of that period in the open state, will now have lidocaine bound to them. That's the difference. You're now giving lidocaine in a dose where you can actually block a good fraction of these voltage-gated sodium channels, far more than would be blocked in the steady state by fleconide. Okay, so you've blocked a lot of them now with lidocaine, but it doesn't have too bad an effect on the upstroke, because before the drug molecules actually got onto the voltage-gated sodium channels, they've let in a lot of sodium, enough for it to actually influence the neighbouring portion of the membrane and for the action potential to conduct. Okay, then the voltage-gated sodium channels will go into the inactivated state. They'll still have the lidocaine bound to them, so this is a good fraction. Let's say 90% of them have got the lidocaine molecule bound to them. And I'm just making up these percentages just to get the point across. 90% of them might now be in the inactivated state with lidocaine bound to them. Then when the electrical potential difference across the cell membrane repolarizes to below the threshold potential, then these inactivated voltage-gated sodium channels are going to take a certain amount of time for the lidocaine to drop off before they go back into the resting state. So understand this is completely different to flecainide. All of the lidocaine molecules are coming on during the action potential, and then they're coming off between the action potential. That's not going to occur in flecainide. Okay, in flecainide, it's not the case that all of the maximum percentage of flecainide molecules that could be bound to voltage-gated sodium channels are going to come on in one action potential, and it's certainly not the case that they'll all come off in between the action potential. So it gradually builds up to this steady state of 30% over time, whereas lidocaine, it goes to its full percentage with just one action potential. That's the difference. That's what this fast on, fast off versus slow on, slow off is all about. Okay, and where were we then with the mechanism of lidocaine? So now, in between the action potential, they're all going to drop off, provided that you wait long enough before stimulating again. So if you wait long enough, if this one's not trying to stimulate this one at too high a frequency, then you wait long enough, and they have all returned to the resting state, and therefore when the stimulation is delivered, it will go through the exact same process again, and you will get an action potential conducted along the cardiomyocyte. Whereas, if you now try and stimulate far too frequently, then let's say you've stimulated for the second time before they've all now returned to the resting state, so only a measly little fraction of them have actually lost their lidocaine molecule and returned to the resting state because you're too impatient, you've stimulated too quickly. Those are now going to be activated to open. You're back above negative 40 millivolts, so these ones now have no desire to return to the resting state. The lidocaine molecule will just remain bound, so the ones that are already in the inactivated state, they'll just now remain there with the lidocaine molecule bound. The ones that had returned to the resting state, they will open, they'll allow in a measly little current of sodium before lidocaine molecules now block them. Okay, that measly little current of sodium won't be enough to actually get spread of the action potential to the neighbouring portion of the membrane, so no action potential will fire, and of course the result of this is that now those voltage-gated sodium channels that had actually recovered in the too short interval period between stimulations are now blocked again. You've put the lidocaine molecule back in, and now they're back in the inactivated state, so you're back with 90% of your voltage-gated sodium channels in the inactivated state, and now in the interval period between this stimulation and the third stimulation, you're now going to have to try and get all of these back into the resting state. And again, of course, if the stimulation is delivered too early, you won't have done, and again you'll get it going round and round with not enough sodium being allowed in the upstroke to actually propagate the action potential onto the neighbouring portion, and every time you do it you're just reaffirming the block. You're blocking back up those voltage-gated sodium channels that did actually get the opportunity to recover to the resting state in this too short interval. So I hope that you have hopefully got the understanding of what the difference between lidocaine and flecainide is. Even though their targets is exactly the same thing, even though they are both use dependent, the kinetics is different, and this determines their use. Okay, this one does not get the chance to come on and off in between each action potential normally, whereas this one does, provided the cardiomyocyte is being stimulated at a feasible rate. All of the drug molecules will go on in an action potential and then come off in between the action potential. Okay, and this is why lidocaine will not block cardiomyocytes from conducting action potentials, provided they are being stimulated at a reasonable rate. And that's of course exactly what we want, because if lidocaine didn't do that, if it blocked action potentials full stop, then you'd block all conduction of action potentials in the heart. This way you only block those action potentials propagating through the cardiomyocytes that are next to these ectopic foci. So effectively, going back to the initial problem, now when the ectopic foci cells are stimulating these cardiomyocytes surrounding them to undergo action potentials far too frequently, these cardiomyocytes are going to completely shut down and say, no, we're not conducting any of your action potentials. Okay, so they turn off all the signaling from the ectopic focus, whereas, for instance, the cardiomyocytes surrounding the sinoatrial node, which we do want to conduct action potentials, even though they're exposed to the lidocaine drug as well, they will be exposed to the lidocaine will be going on and off of their voltage-gated sodium channels with each action potential, but because the sinoatrial node is stimulating those cardiomyocytes at a reasonable rate, then the lidocaine has the chance to come off all of the voltage-gated sodium channels before the next action potential is actually generated by the signaling from the sinoatrial node, and therefore you still do get the action potentials all conducted. So that is the incredibly clever, albeit incredibly complicated mechanism by which lidocaine is actually capable of stopping cardiomyocytes from conducting any action potentials if they are being stimulated at too high a frequency to do so, whereas it will not block them conducting action potentials if they are being stimulated at a reasonable frequency. Okay, so we will have a break there, and in the next video we'll talk about ventricular flutter and ventricular fibrillation.